All right, I'm just gonna go over the case study that we were supposed to go over in class. So, all right, so this is for Unit 10 case study, and I'm gonna post it as well on Canvas, just so you can have it with you and you can read it and you can write on it. Anyway, so we have a 51-year-old female patient with a past medical history of obesity, type 2 diabetes, and arrives at the hospital emergency department with DKA or diabetic ketoacidosis. So, first question, what is the difference between type 1 and type 2 diabetes mellitus? So, etiology meaning the cause. So, for type 1 diabetes, it is commonly autoimmune, hereditary, or viral, right? Autoimmune is when the body's immune system is attacking itself. Hereditary, again, this is genetic. And then viral, so it can develop after a viral infection. Now, type 2, on the other hand, it can also be hereditary, and it can be due to obesity and pancreatitis. In all honesty, the most common reason for diabetes type 2 in our community is obesity. Next, insulin. So in type 1, the body does not produce insulin. In type 2, sometimes it's either one of these reasons or a combination of these reasons. So in type 2 diabetes, there is a decreased production of insulin, and then there's decreased sensitivity and increased resistance to insulin. So again, it's still producing insulin, but it's just not enough. And sometimes the body is just not as sensitive to glucose spikes. And then the body is more resistant to insulin. So it's not really reacting to it. So let's say even though it's producing insulin, it's just not getting that response. Now, their risk for DKA type 1 diabetes, they're more likely to develop DKA compared to the type 2 diabetes. So in type 2, it is possible, but it's less prone than type 1. That being said, sometimes in acute illness, so somebody gets really, really sick, like hospitalized sick, sometimes that's a trigger or a cause for the development of DKA in either types of diabetes. All right, so let's go to the next question. Explain DKA in your own words. So basically what happens in DKA, so the glucose stays out of the cell due to either not having enough insulin or decreased sensitivity or increased resistance, or sometimes just because the body doesn't produce insulin at all, which is what's going on in type 1 diabetes. So then the cell, instead of using carbohydrates for energy, it uses adipose tissue or fat tissue for energy. And as I talked to you guys in class, when we're using fat as a source of energy, the byproduct are keto acids. So that's the byproduct of fat metabolism. So when we have too much keto acid in our blood, that's actually quite toxic. So we develop acidosis. So that's why it's called diabetic ketoacidosis. Next question, the provider orders to start insulin drip or continuous IV infusion. Which specific type of insulin did he or she order? Now, as a vocational nurse, right, as a VN, you won't administer this. But if you are collaborating with an RN, you may be taking care of a patient, right, that has this in collaboration with an RN. So, as mentioned in class, the only medication that you can give IV or the registered nurse can give through the IV is the regular insulin, which is a short-acting insulin. Next question, in your own words, what's insulin's mechanism of action? So how does it work? So again, as mentioned in class, insulin binds to the receptor. So then it basically opens the door for glucose to go inside the cell. And then together with glucose, right, what follows? Potassium. So as glucose goes into the cell, potassium follows. Knowing that, right, next question, upon initiating insulin, the nurse anticipates for which potential side effects. So actually, this is not just IV. Either in subcutaneous form, if you administer insulin, your two most common And concerning potential side effects are two, based on the mechanism of action. One is hypoglycemia. Number two would be hypokalemia, so low blood sugar and low potassium. So that's our main concern. And then knowing that, right, if we know that that's going to be a side effect of this medication, guess what we're going to do, right? Guess what we need to include as part of our nursing actions? That's going to be assessing, right? Checking for that blood sugar, right? So making sure that the patient's not developing hypoglycemia or low blood sugar. And in addition, not only we want to look at the labs, but we also want to look at our patient. Are they having signs and symptoms of hypoglycemia? Same thing with the hypokalemia or low potassium levels. Again, you don't only just look at the numbers, right? You want to look at your patient. Are they experiencing signs and symptoms of hypokalemia? Are they weak? Are they having irregular heart rhythms, especially new onset of irregular heart rhythms? So those are the things that you're looking at when you're caring for a patient who is receiving insulin, regardless of the route. The patient started developing shakiness, weakness, fatigue, sweating, nervousness, confusion, and lethargy. The patient likely developed what? Based on all this, my suspicion would be hypoglycemia, right? So you have to know the signs and symptoms of hypoglycemia. And basically, hypoglycemia is blood sugar levels that are less than 70. Next question. Because of the above side effects, right, hypoglycemia and hypokalemia, in this specific case, based on our assessment, it seems like the patient developed hypoglycemia. The nurse prepares to administer the following medications. So based on our conversation in class, what medications can we give our patient? So based on this, the patient is already confused and lethargic. It's not very safe to give a lethargic patient something through their mouth because, again, as we talked about, they can aspirate. So our options are collaborating with the registered nurse, right? Communicating with them so that they can administer D50. And usually this is ordered together with a protocol. So most hospitals, unless they're a teaching hospital, they will have hypoglycemia protocol. So depending on the blood sugar levels, they will have to give a certain amount of D50. So D50 is dextrose. So that's a very concentrated sugar solution. Another alternative is an injection, glucagon. So what does glucagon do? So glucagon stimulates the liver to basically produce or make more sugar or release more sugar in the bloodstream. The patient recovers and now has discharge orders. Yay, we saved the patient, right? So she will be going home with metformin, 500 milligrams PO BID, so twice a day. You are instructed to provide patient education, and upon reviewing your references, this is what you confirmed. Metformin is from what pharmacological class? Metformin is a biguanide, so this is under biguanides. So that's the pharm class for metformin. Next question, or next information that you want to look up, is the mechanism of action of metformin. So this is how metformin works. When it comes to insulin sensitivity, metformin increases insulin sensitivity, decreases insulin resistance, decreases gluconeogenesis, and decreases intestinal absorption of glucose. In addition, you also note that metformin has the following indications. So indications, other reasons, right? So what are the reasons for giving metformin? As we talked about, it's given for diabetes type 2. So you have to have a pancreas that's still producing some insulin, right? And then it's also given for metabolic syndrome and PCOS. Next, and the following are side effects of metformin. So what are the side effects of metformin? It causes multiple GI symptoms, so abdominal discomfort, flatulence, so basically gasiness, and diarrhea. And then it decreases vitamin B12 and folic acid, right? Because we're not absorbing the nutrients because it basically stimulates the gut so much, so it doesn't give the body time to absorb the nutrients. And another quite concerning side effect is lactic acidosis. Next, the same patient, right, unfortunately gets readmitted to the hospital with abdominal pain. And because of that, they want to do more tests. So the provider or doctor orders a CT of the abdomen with contrast, so with IV contrast. With the provider's orders, your next action includes, so if you know that the patient is getting IV contrast, or if maybe they're going for a procedure and they're going to receive general anesthesia, what should you do with the metformin? So if you know that that's what's going to happen, you have to stop or hold the metformin for 48 hours before and after the procedure or IV contrast administration. And that's very important because, one, you want to prevent lactic acidosis from happening, and then you also want to save the kidneys, right? Because as we talked about, metformin can be damaging to the kidneys, and administering it with IV contrast dye, it increases the likelihood of developing kidney failure or kidney injury. Now, to protect the renal function from the dye, and in consideration of the patient's medication history, the nurse anticipates for the provider to order which medication to protect the kidneys. So that medication is acetylcysteine, or so that's the generic name, and the brand name is Mucomyst. So acetylcysteine is a medication that we use to protect the kidneys. And as I told you guys before, this is a stinky medication. This is a medication that it's also used for respiratory problems. So we can actually give it to patient via inhalation, like a nebulizer treatment. But to protect the kidneys, we give it as an oral liquid oral medication. And like I told you guys, this stinks. It stinks like rotten eggs. And I think that's it. I hope it helps.